for dermatology and plastic surgery here at Modernizing Medicine. I want to thank you all for joining us tonight. We'll start tonight's presentation with an overview of Dr. Moy's experience with EMA dermatology, and we'll follow with a question and answer session. Please feel free to type in your questions at any time during the webinar into the little question panel on the right side of your screen. And we have somebody here who is gathering them, and we will do our best to answer all of your questions. If for some reason we cannot get to all of them, we will follow up with answers after the broadcast. It's my pleasure to introduce Dr. Ron Moy to you now.
Well, thank you. What I'd like to do, of course, is talk about some of the anxieties that we all have as dermatologists, some of the issues that we had, questions we had, and how we've integrated into our practice. And, of course, probably be dealt with best by questions, but I'll just tell you a little bit about ourselves just so you can see how we are probably like many other practices. We do general derm. I think many of you know me as a derm surgeon, so I certainly do dermatologic surgery and Mohs surgery. We have 2 PAs, we have an RN, we have esthetician, we have multiple locations. And since we do all of dermatology, it includes, everything from acne to Mohs surgery to even facelifts and cosmetic procedures and lasers, and it works well. So if during this time and you have questions about, some of the specific, the problems, I certainly can talk with them, but we don't actually have many problems. It's been really surprisingly easy to integrate along with the learning and some of the other issues. For example, I was laughing because when I asked my staff, we all had anxiety, and the people that were not as computer literate would have the most anxiety, and I was one of those people. And the staff thought that I would be the most trouble, that I would be the slowest to learn. And in fact, it wasn't difficult. It was easy. We learned everything from the videos. So we purchased the EMA now July of 2012. We're still learning. We're getting better. One of the things that people will probably ask, how long does it take? Does it slow you down? And I'm going to tell you, it doesn't slow you down during the day, but I do spend a little bit more time when I finish clinic, and it takes me less and less time as I get better. In terms of the previous EMR experience, I had worked at the VA for 25 years, so I had the VA, the EMR that the VA uses. I had that experience, and of course we looked at all the other competitors, and a lot of things are template-based. The VA, as you know, is more template-based. It isn't as easy because of that, and I think you'll see if you sample and look at EMA, how easy it is to click on the things, how easy it is to, even on that first slide, to show where the actinic keratoses are. It is intuitive. So it's designed for a dermatologist. It has some of the esoteric diagnosis. It shows you. It really helps your medical legal charting because it deals with things that you might not normally chart. For example, that you explained all the risks and benefits to the patient, and it goes into the specific possible risks. And having served on the medical board for 8 years in California, every time I came back from a medical board meeting, I always improved my medical charting, but it's still not as good as it is now with all the sort of built-in safety things with your medical records. So I think you can, as you look through this, you'll see even on this this isn't a template, but even on this slide, you can see that we're treating actinic keratoses. It gives you things like counseling, liquid nitrogen, the topical chemotherapies. All the things are sort of listed there. It makes it easy. Because we have visual diagnosis here, it also helps on differential diagnosis. On the times when I'm looking at or trying to figure out something on a patient with a difficult diagnosis, having visual diagnosis there is very helpful, both from a diagnostic point of view, but also to explain things to patients that, you might have this condition, it could be this condition, we need to do a biopsy, for example. That type of presentation to a patient, I think, is they're impressed with that. So I think that, when you look at some of the easy parts that are obvious with EMA, it's clearly the most intuitive, the best for dermatologists. The other way to look at it is it doesn't slow us down during the daytime. I know one of my good friends said their staff wanted another EMR, and it's really because the other EMR was better for the billing staff, they thought. But if you were to look at this as just what's best for the dermatologist, what's best for the physician, it is this. EMMA has much better, it's much faster for us during the day. So for example, we go and we have multiple iPads, and our medical assistants walk around with iPads. I very rarely will actually use the iPad myself. Usually there's always a medical assistant. They already have the diagnosis or the presumed diagnosis walking in, or possible diagnosis. They hear me speak to the patient. It might be something like actinic keratosis, but it might be something more complicated. It might be acne and some other thing. And then as they hear me explaining the therapy or explaining the differential diagnosis, they're already punching things out on the iPad. So really, I don't touch anything during the daytime. And then after clinic or at home, or sometimes convenient, every once in a while, even the next day, I will go back and just basically sign notes. And generally, I'm just looking at the billing. And that's probably the other big advantage of EMMA, is that the billing is much faster and much more accurate than it was when we did charting. So in terms of practice productivity, on an average day, I used to see 50 patients a day. I still see 50 patients a day. That has not changed our practice productivity at all. And I know my other partners feel the same way. I think our notes are more accurate. They're obviously more legible. ICD-10 is something that's, I think, on everybody's radar screen. And actually, with EMMA, you don't really need to know, you don't need to know as much about ICD-10 or anything about ICD-10 or really billing, because everything is automatically billed. For example, we put down, if we're seeing an acne visit plus somebody has moles, it gives us the right code for a visit. If we're doing Mohs surgery and we put down 3 stages of Mohs, it automatically builds that out. So in a way, coding is simpler, and the same with the diagnostic of things. ICD-10 is actually something that's somewhat superfluous in that it may change, but with this EMMA, you don't need to know a lot about it. And then evolution of the product, it certainly is evolving, and it's gotten better since we've used it. It's not dramatic changes, but little changes. And they're mostly on things that we do. For example, if I do a facelift, I want a facelift op note. And there's both. Not only is there, maybe I should use a better example, laser resurfacing. Since more of us do laser resurfacing, there's a consult for laser resurfacing, and then there's the actual procedure. And that's really good to be able to have a note, a pre-op note, for example, that explains all the things, all the possible scenarios with laser resurfacing. And then there's a very good op note that is basically similar and explains all the things, or at least documents all the things that we should be documenting. So the product has gotten better. Visual diagnosis, as I mentioned, is another good part of it. I think that, I can't even see the product getting better in a sense that it does everything. The only thing that I would like, of course, is to be faster and faster, and I think that's partly me. So with that,
so we are already getting a number of questions that are being sent in, and I think that a lot of you will probably have more and more questions as we hear some questions that others are asking, and that can really help us to really guide this conversation, because Dr. Moy is really giving us his time very generously, helping us to really deal with the questions that you're struggling with as you decide, will EMMA work for me? Maybe some of you have already tried another EMR. In fact, I recognize some of your names on there, and I know you have. And others of you are trying it for the first time or seriously thinking about it. So why don't we move into the questions, and then we'll kind of continue this discussion.
Okay.
So I know that we kind of touched on how EMMA compares to the EMR, which was template-based at the VA, but is there anything else that you want to kind of elaborate on as far as how it compares to other EMRs that you've seen? Real key differentiators?
I think the key is that this was written by a dermatologist, so I think we think differently. For example, any other EMR, we as dermatologists sometimes walk in, know the diagnosis, and then go from there, may implement therapy. And I think that is maybe half our day. It's not always, we always keep a differential diagnosis, but that saves a lot of time. And actinic keratosis would be the example. We know the patient has actinic keratosis already on the screen, therapy of cryotherapy. and so it just set up, and only a dermatologist who designed this could have something that's so intuitive and much easier for us. So I think it's really hard to compare any other EMR that we looked at.
Perfect. Now, what parameters do you have in place to base your decision on choosing Emma versus other EMRs?
Well, like all of us, I think, I talked to my friends, people who had Emma already. Everybody was happy. We all have colleagues who are unhappy with their EMR, so I ran into a couple of those. But I think you have to try it, and maybe like everything, there are programs that fit better. This is very visual, it's very intuitive. I think I mentioned that we did not use any of the formal training that Modernized Medicine offers. We actually had our staff look at videos. We started slowly. We started maybe doing 4 or 5 patients a day. And with that, we did not, our medical assistants teach the new medical assistants. We did look at these videos, but we were able to learn ourselves. I think it's that easy that it's very intuitive that anybody could teach themselves. And actually, one of our other physicians was just telling me, Helen Fincher was telling me, that she never looked at the videos. She just learned intuitively.
Just picked it up. That's incredible. Yeah, wow, that's amazing. I thought that you had done a good amount of on-site training, so it's interesting that you were able to pick it up that quickly and easily.
Yeah, no on-site training.
That's awesome. Okay, great. So the next question we have here is it easier to complete a note on a Mac or a PC, basically the computer version, or on an iPad?
I usually use a portable computer, or MacBook Pro. And I think it is a little easier. Sometimes the formatting on the iPad is not as good. I think there are people even who would use the mini iPad and they work well. But for me, I think the typing is easier on a MacBook Pro. And I know one of my other partners uses in her office uses a regular PC. So I think that's just a personal, preference.
Okay, and you find that your MAs use iPads though?
Yeah, iPads. Yeah.
Okay.
But a quarter of them use the mini iPad, and most of them use the iPads that we offer them.
Okay, great. So this is more of a question about support and training. If you have ever needed Emma for one reason or another, or the staff at Modernizing Medicine, how do you typically request support, and what is your typical response time?
Well, to be honest, I haven't done it. Everything has been smooth enough that I have not had to call any of you. We have our PAs have called you for specific questions and then relayed them back. But from what I hear, it's always been fast and quick. We've gotten all the answers, so we haven't had any issues with that. We haven't had a lot of questions. I think it has been fairly easy to learn. So that for that reason, I don't think we've had a lot of questions.
Great. All right. So this is more about a usability. And is there a delay in pulling up previous visit notes on the iPad, or do you print out your previous notes and then have them in a paper chart prior to seeing a patient?
No, we do not use paper anymore, and we do not. There's maybe a few things that we have to do. We have an ambulatory surgical center where we have to, but we really just use the computer and the iPad for everything. Is it as fast? Sometimes you have to wait, a little pause, but certainly a lot easier than looking for old charts. Certainly it decreases the amount of time the file clerk per position. There's other things. We are still scanning documents into Emma. Sometimes things that are sent to us need to be scanned. We may scan a Mohs note. Obviously the photographs are a lot easier because we take our photographs with the iPad. So many of the documents that can be scanned, we actually do it by photographs. But if you're asking, is it slower? Overall, it's faster than doing charts. And I mentioned the one time that sometimes you have that may slow you down a little bit is just signing the charts at the end of the day or checking over the charts.
Okay, great. Thank you so much, Dr. Moy. So the next question is kind of a workflow question. Can you have 2 different medical assistants enter data on the same patient at the same time using different iPads?
Yeah, we do, although Shelley you can answer that better, but we do it all the time.
Yes, so that's exactly what I would say. So I know that is a huge differentiator between us and client-server systems. With the client-server system, you can only have one device on a chart at any time, and you have to save it before anybody else can go on. So a lot of people who are looking at client-server EMRs really may not understand that is a huge benefit to being on an actual EMR that's in the cloud.
Oh, okay. That's a big advantage to know that.
Yep, definitely. So let's see. We already answered that question. And I kind of almost think that we answered this question in your intro, but are you taking big steps to prepare for ICD-10, or are you just kind of relaxing because, Emma has it under control?
Relaxing. I mean, I think, when I was in leadership positions in the academy, we always knew that was coming, and I think the academy certainly tries to prepare its members. But really, having Emma, it's something I put aside. I don't think we have a great need. I think Emma takes care of all that, and so I'm not worried about that.
Excellent. Okay, wonderful. How quickly and easily can you scan past photographs from a Mohs patient to review where there are numerous skin cancers? And in addition, can you click one button for a thumbnail view or all to see all the photos taken on that patient? Or do you have to track through encounter by encounter? How do you manage photos?
Well, we, first of all, if you're just talking about a Mohs patient, we do everything on the iPad. And you can scan, and Shelley, you probably know the answer, 6 photos at a time. How many photos can you look at a time, I think?
You can see a whole grouping of them up at the top and then just kind of tap on the one and pull up 2 side by side at the bottom. But you can see, a bunch of thumbnails along the top.
Right. So you can look at numerous photos. Now, if this particular patient has more than just, say, 5 or 6, then you have to scroll through that and you can bring it down. But it's fairly easy to do that. In terms of scanning past photographs, we have past photographs on paper. We don't store past photographs in Emma, though, right?
You mean the ones that came from your paper charts before moving forward?
There's no way to do that.
Well, if you have them, let's say, on a computer or a server, you could go into the computer version and just select them all, and you could manually attach them all to the chart. You definitely could do that. If you hadn't been doing that and instead were just printing them out and hadn't, been saving them in folders that would make it easy to find them, then, you might just want to look at your paper chart. It really depends on what your photo management system was before moving forward with Emma, I think.
Right. So in truth, we don't do that. We obviously have Emma. We have all the photographs we've taken with Emma. Anything in the past still in the paper chart or in the old computer system. It's still in the computer, but we have to search through that. So there's usually not a need for that. I actually have not had a need for that, so I've never run across that.
And actually, I'm going to make my own follow-up because people ask me this all the time, Dr. Moy. In fact, we were just at a practice where they were asking us this 2 minutes ago. What did you do with your old paper charts?
We store them. So we store them a couple miles away. We have some here, I think, but we don't use them.
And how did you decide what you wanted to scan in?
We actually just do things prospectively. We don't scan in a lot of past things. If we feel like we need the chart, we'll request it, but we didn't scan in a lot of stuff.
Okay.
We're not spending a lot. I shouldn't say that. There are things we are scanning. I'm not sure how we decide that. I haven't been involved in that. I think it's rare that I get a past chart. So some of my partners might have asked for certain things to be scanned. I don't think it's much. And I think the people scanning documents, it's mostly new stuff that we're scanning. It's some of the biopsy reports. It's maybe some letter that was important. I don't think we're scanning much in the past.
So it sounds like right from the beginning almost, you kind of had enough in Emma after the first visit to just keep looking at Emma, and you didn't have to worry too much about the paper charts.
Right, and even the little things that some of us like to write little notes like this patient plays tennis, or this patient a little social note.
Right.
My long lost cousin that I forgot their name, or their wife. Those little sticky notes. So there's places that you can put little personal notes that you might write on the side when you had medical charting.
Perfect. Okay, well this is a great question. So from this participant's perspective, Emma was designed for a scribe to stand in the room with a general dermatologist. And that's not necessary, but a lot of people do use it that way. That's Shelley's own side comment. But their specific question is, how about as a Mohs surgeon? Do you as a surgeon create the entire Mohs note, or do you have MAs, your Mohs tech, or nurses create it for you?
They create all of it. So it's mostly just signing a chart. And to be honest, what I will do is just look at the codes, look at the Mohs code, make sure the repair code is done.
and the ASC, and those things are all done. Now that I trust Emma, I don't need to read the whole note anymore, so that saves me a lot of time. But it works well for a Mohs surgeon. I know other Mohs surgeons who have it. I think that it may not be the way you did Mohs before. A Mohs operative note, so you convert it a little bit, or I'm sure you can customize it too if you wanted to. But we've adapted it well. So in the end, it's faster. I probably do less. I used to do, I think we all have done some version of either dictation of op notes, and this is, or we templated op notes, and this is basically the same thing. So a typical Mohs op note, they ask you the size. You fill that in, or the medical system fills that in. They fill in the number of stages. You have a choice of every type of repair possible. It's not that, you just pick transposition fat flap. So it's more detailed than, say, the coding is. And in a sense, you come up with a better, actually in every way, you come up with a better operative note than we did when we were either dictating and forget something. So I think that, you may look at this and say, well, it's not the way you do it exactly, but I think with the photographs right there, even the pictures that you saw with the actinic keratosis, that first photograph, you basically click on to where the lesion might be where you're doing Mohs surgery, and it's very detailed, and it could be columella, ala, it could be, every part of the ear. So it's a very detailed anatomy. But basically, you're just clicking on to the sites, so that makes it fast too. So the medical systems aren't spending more time. I mean, I've heard friends say their PA has to spend, overtime, and they're doing all this stuff. Our people, we're right here. I think Shelley was, as our medical staff was leaving, they're all out of here with no overtime, leaving by 5. So even for them, it's not bad. Every once in a while, the worst I could complain about is one of the medical systems forgets to do one of my op notes, and I might have to do it myself, or we have this intramail thing where I can remind them the next day, hey, please do my operative note if I'm really lazy. But actually, it's so quick that I often will spare them, and it takes me just a couple minutes myself, and I'll just do it at nighttime, and they never even know that they forgot.
Perfect. Okay, great. Thank you. So this is another workflow question about how you function with your staff. And the question is, can one work with just 2 assistants out of 3 rooms? The doctor that I visited that was using Emma had 3 assistants, and each of them with their own iPad. Each was waiting outside of their room. I'm wondering how difficult it would be to work out of 3 rooms with just 2 assistants. How quickly can you switch from one patient's chart to another if you're bouncing room to room?
Well, it's very quick. I mean, for me to see 50 patients a day, I'm doing that. Every once in a while, I'll walk into a room and there isn't a medical assistant. And usually the iPad's already sitting there with the patient's name in there, and I might type in a few things myself. Sometimes I will actually maybe even forget to do that, and I'll have to remember, an hour later. But it's easy. You don't have to do that configuration of 3 medical assistants. I sometimes feel like I hardly have any assistants during the day as we're lowering our overhead, and I sometimes am lucky if I have 1 assistant a day or 2 assistants. So I think it can work to everybody's way of managing their practice. It doesn't have to be that method of 3 assistants to all sitting outside the office. I think it could be manipulated many different ways.
So I know that you see 50 patients per day because you mentioned that earlier, but on a typical day, how many MAs are assigned to you?
We work as a group, and that we don't have that. So we have, there might be 3 MAs working, 3 of us sometimes, or 2 of us. And so we may have, but we have a PA working with us sometimes. So we don't have that same set thing. I don't think I really have 3 medical assistants on any given day generally working with me. I think I'm lucky if I have 2. And I may have a Mohs tech help me out from time to time, and I might have a PA help me out from time to time, but I don't have 3.
Okay. Well, that's great. That's really, really helpful. People ask us those questions all the time. Now, one doctor seems to have a number of questions that are tied to more things around looking for patients or things that relate a little bit more to meaningful use. And I don't know if you do this type of thing, Dr. Moyer, or if this would be your staff, but he's wondering, can you search for patients with a certain diagnosis and prescription?
I haven't done that. So you know the answer.
I do know the answer. So the answer is yes. That would be under the advanced patient search area of the program. You don't find it on the iPad version, you find it on the computer version. And you can type in melanoma, or you can type in psoriasis plus Enbrel, and it'll find all your patients with whatever diagnosis or whatever prescription you're on. The same person has some questions about recalls. How do you handle recalls in your practice?
I don't think we've implemented that. You actually, it's another area that we need to learn more about.
Yeah. So Emma doesn't. You can set reminders for Emma, but I do think that a lot of people do things out of their practice management for that. So I was wondering if maybe you had kind of created a process outside of Emma.
We had an old method, but no, we haven't really. Something we need to work on.
Okay, cool. And how do you put past reports into the chart?
We scan them or photograph them.
Okay, great. And so there are certainly ways to have them go in electronically, but sometimes I do agree that doctors just like to get a stack of past reports, they write on them, and the staff can just take a photo or scan them in, and it's really efficient for the doctor that way, and that's the most important thing, right?
And there is a way for the pathologist to be able to electronically send it. We haven't. I think we started thinking about that, so that may be the way to do it in the future.
Yeah.
Prescriptions. Did you mention that prescriptions are simpler? So
no, but please.
So the other difference, and I guess this is part of Obamacare, is I no longer carry a prescription blanket with me, a prescription pad, because everything is electronically done, and that's also faster. And I think even better in the way that we prescribe things. There's some checking mechanisms that it tells them the dosages. But basically, the medical assistant just clicks on the possible drugs that you may be prescribing, whether it's doxycycline, and you click onto that. At the end of the day, or after you see that patient, you do need to click on it. So it just electronically goes to the pharmacy. And that at the beginning, I thought that was an issue. It turns out to be faster, easier, quicker. I've gotten very used to that.
Excellent. Perfect. One doctor wants to know, what practice management software do you use, Dr. Moy? Do you do in-house billing? Do you have Inga-Elzy do your billing? What do you do?
Well, we use the one that's associated with you, Advanced MD. That works a lot better. We previously used Medical Manager, which I think was commonly used by many of us. Our billers say this is better. It's a better program. They're very happy with it. It obviously integrates well with Emma. So we do it in-house because we always figure that it's still better to have the billers here. It's better service. And they've been happy with Emma. It also allows them to go and sometimes they will add things like on a cosmetic patient, did the patient pay at the desk? And I sometimes wonder, did they, did we charge them Voluma or something? And they go into there and will, right in there, the patient pays that. Or sometimes when we haven't done something, the billers get involved, that they can go back and search something when the insurance company asks them, they can look at things better. So they're happier with electronic records than when they used to have to look for charts. They were always looking for charts.
Great, perfect. Another doctor would like to know if you use Dragon Medical with Emma, and if you don't, do you do any voice dictation with Siri, the native voice recognition in the iPad?
I don't think you need to, Emma, that everything is it's already in there. So no, I haven't done any dictation for a long time.
Okay, great. If you were 10 years or less from retirement, do you think it's worth the time and money?
Well, I probably am 10 years, and I think it is worth the time and money. I mean, for one, there's the penalty. Secondly, I think people are starting to realize the perception that almost everybody has electronic records. You'll be perceived as being very old-fashioned. I think that overall it's better for patients, and maybe I'll politicize this. Probably one of the good things that President Obama has done is implement this or require us to do this. So I think it is worthwhile if you're 10 years out from retirement. I know people that are even closer to that, and they're still getting Emma. So one of my good friends has done that. He's probably very a lot closer. He's beyond that. He probably could be retired. He's over 65. So I think a lot of people are doing it.
And I think it was interesting that you mentioned about patient perception.
Mm-hmm.
I think in a lot of practices that I work with, they have the opposite fear. They say, I hear patients don't like EMR, or I don't think my patients are going to be comfortable with this.
Well, they don't like it when you don't look at them and they think you're getting less contact. But in this case, as we were talking, our medical systems are sort of in the background as a scribe or whatever you call that. But I still spend as much face time. Maybe even less. I'm not signing anything. I'm just looking at them directly. So I don't think they would feel that.
Perfect.
That's what you probably found. So.
Yeah, definitely, and I appreciate you saying that. So let's take a look at some of these other questions. Somebody wanted to know, do you print and mail notes to referring physicians? Are you able to email a digital letter? How well does that work for you?
It works well with this. So the photographs, as we said, are already in Emma. The letters can be typed, and it's typed on our letterhead. So for a Mohs surgeon who needs to send, pictures and letters, it works very well, and that works as well as any of the other programs that have been designed for Mohs surgeons. It's good.
Excellent. How do you flag a cancer or a lab that requires attention?
We don't do that. There are ways to do that, Shelley, right?
Yeah, there definitely are. But yeah, people ask us that sometimes. They're kind of thinking about having a high-risk patient and they flag their chart in a certain way. So
I don't understand. So if when we get a lab test, we look at it still on paper and we follow the patient. You're talking about something that's only electronic and it would flag our attention, or that patient will always be flagged because they.
I think it might be a sticky note might be the way to do it because it pops up. I'm not exactly. I don't know the exact right answer to that, but certainly it seems like you're giving your patients good care. So one way or the other, you seem to follow up with them appropriately. Can you describe how someone in your practice gets the path report from the path lab, and then how that information is communicated to the patient?
We do it the same as I think every person does. I mean, in more recent time, I like to call my patients who have cancer, so I do it myself, but generally somebody calls them and tells them, what their path is from, and we're still doing it by paper. Shelley said you're saying that we could do it electronically too if you wanted to.
You could, and I think that there's kind of a split between Emma users. Some people have the reports come in electronically and they're automatically go right into the path log and also into the patient's records. But some people just like to have a stack of path reports waiting for the doctor, and I don't think that there's any wrong or right way. That does not affect meaningful use in any way.
Right.
So it's really just a matter of what you find is really efficient for you.
Yeah. So we're still paper. We're paper, and then we scan it, and then we throw it away.
Perfect. Great. And so there was one doctor using Emma that told one of our attendees that he scanned the pages from his old paper charts when a patient returned for a visit and created individual files such as old progress notes, old op reports, old path reports, etc. But it sounds like you didn't do this, Dr. Moy. And does creating all those old files from an old chart jam things up? So I guess, the question is, what are the pros and cons to either scanning something in or not?
Are they asking, does it slow up the computer part? That you probably can answer that, right? It probably does not. You scan a lot of stuff in there, does it slow things up?
Right.
You could do that. I think if you're, sometimes maybe it is good to have all charts. It's rare, I guess. I think you could do that, and I think if you're really compulsive, I guess when we get into a complicated situation, we're still requesting the old chart. It's difficult to get the old chart.
Right. Okay. And I do think that, it's not like the old chart disappears. You can always reference it. I think that's a really good point. And that means that your staff isn't really burdened doing a lot of scanning. You just kind of start fresh in Emma.
Yeah.
And
well, maybe that's the most important point, because if you did do that, you could be working forever scanning, 20,000 charts and 30,000 charts.
Without all that much return on investment.
Right.
Great. So when you started implementing Emma, right? There's lots of different ways to kind of phase it into your practice.
Mm-hmm.
And if you can think back to when you first started using it, did you start by using Emma only on new patients, or did you just dive head first and do it on all of your patients?
We did it the way you advise us to do that, which was to start small. And, first of all, I think you call it a sandbox or something. Mm-hmm. And we tried different patients, or we tried to create false patients, and we did it that way. And then we started slowly. We started with just a handful of patients per day. But within a couple of weeks, we were almost up to our normal case load. But we were probably a little bit slower than we are now.
Okay. And so you were doing some patients on paper and some in Emma, and then transitioned to them?
Yes, transition.
Right. And I think when we were chatting the other day, you said that you never actually cut back on patients. So when you said you were slower at first, it was slower in documenting and
right.
Not in the number of patients you saw.
Yes, yeah. We never did decrease our patient load.
Excellent. Great. So do you use the patient portal in Emma?
No. That's where the patient can look at their own records.
Right.
Us partners have discussed that. Is that something that a lot of people do?
Well, it is required for meaningful use.
Oh, it is?
Did you meet meaningful use this year?
We did.
Okay, so you are using the patient portal.
Yeah, we are. I didn't realize that the patients are going to they at least have the option of going to their...
Yeah, in the patient portal, it doesn't have everything. It doesn't share their actual chart notes.
Oh, okay.
Right? That's what doctors oftentimes are afraid of. They're going to see, the patient has, I always forget the actual diagnosis, but, they think that there's bugs on them and there's not, or whatever it may be. And so it's not the entire chart note that's up there, but patients can put in their medical history ahead of time, and they can receive an electronic summary of their chart, which is important or required for meaningful use. They can get their clinical summaries. And if you have your path reports coming in electronically, they can actually push those up. That's a button you can check. But it sounds like you're not using it at least for medical history. So do they have a paper form that they fill out when they check in, or how do you gather their medical history?
We do. We actually have a form that supposedly encompasses everything that's required. And some of those things even are weird things that old people always ask, like, why do you require whether we're sexually active, or, and they're sort of embarrassed by asking. I was embarrassed by even trying to answer that. But so they just check that off by hand, and then we, of course, put that into Emma. So I think that we do meaningful use, and I didn't know about the patient portal, but I don't think we actually tell patients, really, right? Most people,
right.
Those patients don't know that they have that option.
Right. With stage 1 meaningful use, they didn't actually have to log in.
Oh.
It actually just had to be enabled.
Oh.
So that may have been...
that's where we are.
Yeah, exactly. Okay, cool. So let's see. So one practice shares that they have a path log to keep track of biopsies. Each biopsy we do gets a chronological number for the year, etc., and we write the diagnosis as the result comes in. They'd like to know how Emma handles this. They'd like to know, is it a log per se, automatically created that the physician can review? How do you know that a biopsy result doesn't slip through the cracks?
Well, it's probably another one you should answer, Shelley, because we still have a logbook, but we're still using the old method. But I know there's a way, and we haven't implemented that.
Oh boy, I need to spend some time with Dr. Moy.
Yeah, because we didn't take the courses.
So yes. When you coming back here to this image here, when you actually do a biopsy or an excision, it automatically puts that specimen that specimen right on the path log. And then when you post what the result was, like let's say it did turn out to be basal cell, you can say what you want them to do. So schedule an excision, schedule mode, whatever it may be. And then there's this whole screen that tracks pending plan completion. So if you have a whole active list of biopsies and excisions that you're manually and actively tracking to encourage the patients to come and get treatment, et cetera. And then you only mark it as complete when they have come in for the excision, and the next path report is back and the margins are clear. But that's definitely something that is totally automated, and something we'd certainly love to get you a little bit of training on, because I think that would save your staff a lot of time that they're manually doing things. Okay, so how do you input the Mohs map? Do you draw and scan it? Is there a template in Emma?
The way we do it is we have our old Mohs map and we just take a photograph of it. Is that how most
It is.
Oh.
Yeah. So even though you can take a photo of a patient and draw on it, most Mohs surgeons I find really love their Mohs map, and they just snap a photo of it. It's just as easy as taking a photo of the patient.
Yeah.
So, yep, that's exactly what most people do. How do you handle patient messages through the day? So, for example, a patient calls in with a question about X, staff wants to route it to you. How do you handle all of that?
It's important to document that. Again, one of those medical board things that I learned. It's important to document responses to phone calls. So I usually hand it back and tell them to scan that in on the photograph, and I will type something in, whatever I did. If it's a prescription, obviously it's in Emma already. But it is important for staff to always document all these phone calls and things like that. But is there something special for that?
Well, there is intramail in the system, and I think that you said that you do send intramail.
We use a lot of intramails.
You forgot my op report.
Yes. Yeah. So that's true. A lot of back and forth between the staff is not by email. In our office, is now by intramail. And on a given day, I probably have an average of 6 intramails from the staff. And it's questioning about a patient. Sometimes they even say, call this patient, because they know I look at that more often than I will. Because I have to sign prescriptions and things, I may look at intramail more than I look at my emails. So sometimes they put the, call this patient back or something like that.
Perfect. Okay, great. So how, they want to know, does Emma name the location of a biopsy, or really, anything for that matter? And are you okay with the naming of the location?
I guess you're asking, when we click onto something, let's say it's nasal ala, Emma, you look on the slide there and it says nasal ala. You can agree, you can actually go down farther and say, well, it was really not nasal ala, it was really nasal supratip. And then you can change your mind if you want. So it does with that click. Sometimes if you saw that big face picture, if it's a smaller face picture and you're moving the little clicker, you have to be very careful and get on the nasal supratip and not get on the nasal ala. So that takes a little bit of learning. So Emma doesn't really, Emma doesn't name the location. You're clicking onto the location. Now in words, the difference between nasal ala and nasal tip, you have to agree with that, and then you consistently use that. So I think it works. I think that system works very well.
Perfect. One nice enhancement that I just learned about with our latest iPad version is if you don't just tap on the image, if you instead just hold your finger there, it'll actually highlight the area and tell you the name of what it wants to call it. So if it's not in the exact right spot, you can move your finger slightly over, and then you say, oh, yeah, that's exactly the supratip, and then you tap. So that's a brand new feature that we just came out with, because you're right. Sometimes you kind of had to memorize the images. And so now if you kind of hold your finger on the image, it'll highlight it and tell you what it's going to call it before you tap it and commit to that location. So it's a pretty cool new enhancement that I just learned last week. So somebody has a question about how your assistants use iPads. So if an assistant has logged into an iPad, can that iPad be passed assistant to assistant, or do they have to stop, re-log in with their ID? On the same line, can the doctor grab the iPad from the assistant and tap away without having to log in?
That's a very good question, because there's always that blame in an office. Maybe blame isn't the right word. You could say the positive side, credit. So if somebody is the one who signed on and I see that they did something wrong or they didn't finish the off note, we know who it is. So who logged on actually is important. What happens sometimes in a busy office is somebody logs on often, and then the other medical assistant will be the one helping. And we had to train everybody as the second person has to then log on, so to take responsibility or to take credit for whatever is written down.
And it's pretty quick to log in and out of the system, right?
Right. And I said I rarely log on during the day, but I could too if I was caught by myself and I have to do that, then I can log on myself.
Excellent. Okay, great. Have you implemented any methods for protecting your patient's records from being hacked?
I left an iPad on an American Airlines flight in the thing. And I thought, I do have password there, but as you know, we treat a lot of movie stars here in Beverly Hills. I thought, okay, that could be a problem. So that's the first security. It's, you know, I mean, I know, Shelley, this is probably more of a question for you. I don't know all the hacking methods. I suppose, can people get in?
You know, I'm not a hacker.
Okay.
I'm just a simple software salesperson.
I mean, you're a hacker,
No, I'm just teasing. But, you know, Emma really is secure. We use the same level of encryption as they use for online banking. So just like you can go, you know, with your iPhone or your iPad with an app into your online banking and you're not really worried about, you know, somebody suddenly getting your bank account information, it's the same thing. We do a lot for security. But it sounds like your answer is that you just kind of have peace of mind that Emma is secure for your patients.
Yeah.
Okay, great. And by the way, thinking way back when we still weren't Stage 1 meaningfully certified a long time ago and we were going through the different modules, the very first thing that we got certified for was security. It was something that has always been part of our program, and it was very, very simple for us to pass the government requirements on that.
It's really more secure than having a chart. Like when I was at UCLA, they got in trouble for movies. You know, somebody could look at the chart too. I guess somebody could look at a medical record. You know, we of course in our office make everybody sign confidentiality, HIPAA form, HIPAA confidentiality. So I think it's always a concern, but I haven't heard of any problems.
Okay, excellent. How do you handle a patient who adds on several complaints after they have already been processed by the MA? Especially if you're alone?
Well, it's pretty simple. You know, you're clicking on more impressions, so it's and what Emma does is it gives you the ones you use most commonly. So in my practice, I might say skin cancer, cosmetic. The most common things people have nevi or something, or actinic keratosis. Those are the most common things I click on. Generally, if somebody comes on with something new, it's going to be one of those things, and then it's just a click. It's not even writing.
Perfect. So yeah, Hey Doc, by the way, is not a problem. Great. Can you, and this actually I think has already kind of been answered, but the question is, can you edit the location where your medical assistant put the AK on the face mask?
Yeah, so that is why you're looking at charts. It is more accurate because you're supposed to check everything the medical assistant does. You know, I said I cheat. In a busy day, I might not look at every medical assistant, but you could. If you were looking at every record, you would notice the medical assistant put on the wrong location, and you could change that. Physician is the one finally finalizes the chart.
Excellent. And do you use local IT techs for hardware maintenance? How is the software backup with Emma? Is it fast, average, poor?
Local IT. So yes, there are people who help. We use just a local guy that we've used for 20 years, and he said no problems integrating that in our computers. And we of course converted to more of an Apple system, so that there was a little bit of a change there. And software backup with Emma, fast meaning how fast is it?
Well, I'm not even sure exactly what this question is. I think that this is somebody who may be really thinking back to a traditional client server system where they have to back it up every night.
Oh, okay. So this is in the cloud. We don't have to back it up. And maybe they mean how fast does Emma work? It works fast. It's as quick as any.
Excellent. Thanks, Dr. Moy. Is the entire program the same on the iPad as on your PC or Mac, or is it an abbreviated version?
I guess you should answer that,
Sean. Well, there are things that differ between the two. The iPad is our clinical tool, and that's really what you use as you move to the clinic or the OR. And so it's great for photos, it's great for drawing, it's great for signing consents electronically. All of those things you can't really do on a computer version. Sure, you can take a photo with a traditional camera, save it to the computer, and then manually attach it, but it doesn't instantly go into the patient chart, and you can't instantly label it to the diagnosis, procedure, and location. So the iPad actually does something better than the computer version. Same thing with voice recognition. Voice recognition is incredible on the iPad. So anybody who does that, you know, if you do think you're going to do dictation, you know, even adding little bits and pieces of the iPad, you know, is substantially better than the computer version. The computer version has the path log, and it has your home screen, which is where you can kind of see a list of all your patients. Although I always have my customers log in to the home screen on Safari right on their iPad. And now if you're having Emma run in the background, you can kind of switch between Safari and the main iPad version with a 4-finger swipe. So that home screen being on the computer version is kind of a non-issue at this point. But those are really the two primary differences between them. Document management and faxing, actually faxing doctor referral letters, creating doctor referral letters, that's on the iPad or on the computer version and not on the iPad as well. So there are some differences, but as they were designed, they were meant so that you have the tools that you need when you're mobile, and when you're sitting at the doctor's office or the nurse's station, you have those tools as well.
You mentioned the consent form, and that's sort of a neat feature, especially for old people. You know, they go, I'm signing with my finger, but the consent's already in there, and so we've gotten used to that. I think that actually is nice.
Perfect. So this person says that they use paper labels for past specimens, and they would like to know how you handle the labels on the past specimen bottles.
We do have labels printed now, and I don't know how we do that. So I'm gonna think that it was printed off our advanced MD. Is that they print labels? How
it's actually right on our path requisition.
Oh, it is. Okay.
So Emma generates your path requisition automatically.
Oh, okay.
Just again, same thing. Right when we document the biopsy, it not only puts it on your note and puts it on your encounter form to bill for it, but it generates a path requisition. And if you have the right kind of paper, you just pull the peel-off sticky labels right off the bottom of the path rack.
Oh, okay, that's how we do it. Okay,
yeah.
Good to know. I don't know this.
Yeah. That's what you have NAs for, right?
Right. Good office stuff.
Exactly. All right, great. Do you know how your front desk enters patient data in? Do they transfer from? Oh yeah. Do your patients? Well, I think we already answered this. Actually, you have your patients fill out their medical history on a paper form.
Yes.
And then I guess the bigger question is, do you have your front desk staff or your medical assistants take that information on the paper form and go in and fill out the medical history fields in Emma?
The front office.
The front office does. That's great. And I always talk to people about how you're going to kind of transition from one role to another. Today, if you're in a paper environment, you're doing a lot of pulling charts and filing charts. But I'm sure that there was a big transition going into a paperless environment in the duties and jobs that needed to be done by your administrative staff. Mm-hmm. So I would love it if you could kind of discuss a little bit about maybe how people's roles were maybe morphed, and also, you know, whether you ended up losing staff or not. People ask me that question quite a bit.
So I don't think we lost any staff. Now, I'm 56, and I'll say, so I won't say this, but I'll only insult myself, but people in their 50s might have a harder time, and I'm one of those people. So we have one medical assistant who's my age, 56. I think it was harder for her. She was resistant, but she finally learned it, and now she's very proud that she learned it. So that has worked out. If you have somebody who's not very smart, it probably requires the intelligence to be a bit higher for a medical assistant. I think you need smarter medical assistants, or the ones that do well are sometimes the younger ones who are more computer literate. Hasn't changed our hiring, hasn't changed, you know, the amount we offer. And in terms of staff, you know, the file clerk does more scanning now. They're not looking for charts. Maybe that position changed. Medical assistants, we've sort of gone over it. You know, they're doing iPad work. The front office, I don't think it's changed much for them. I guess it depends on which practice management system. There are others that integrate with you, right?
Mm-hmm.
And so there is one that bills, like somebody asked whether they use Inga LZ. Isn't there one that bills for you for a fee? There's the one that we have, so there's some choices there.
Right. We have a number of systems that we have real-time interfaces with that automatically pull in demographics and insurance and push out the charges when you finalize the note. Advanced MD was one of the very first we did it with, and it's still the one that more of our customers are using than any other practice management system.
And it did allow us to transfer all the information, the demographic information from medical manager seamlessly, so that was easy. We didn't lose anything.
Perfect, perfect. Well, it looks like we are running out of time on the webinar. I hope that this was helpful for everybody. We certainly appreciate Dr. Moy taking time out of his busy, busy day and sharing his experience with us. We really do want to thank you so much for your time, Dr. Moy.
Usually. And I learned a lot.
Oh, good, good. Well, that's the silver lining, right?
Yeah.
For your generosity. So thanks, everybody. If you have additional questions, please send them in to sales or derm sales, DERMSALES, @mondmed.com, and we'll be sure to get you some solid answers. And we look forward to seeing you at the AAD. We're going to have a great appreciation event on Saturday night. We have a really great band this year, like every year. So be sure to stop by the booth, and we'd love to have you join us for our appreciation event.